Please welcome Dr. Grant Stevens, Dr. Lori Cassis, Dr. Jennifer Harrington, Dr. Sachin Shridharani, and Dr. Holly Wall.
So while our esteemed experts, hey Holly, are coming up to the stage, I just want to set the stage a little bit, my own personal experience. Maria Acevedo is somewhere around here. She and I have worked together for 33 years since May 1st. And she'll tell you that 33 years ago when I hired her, I said, I want to discover the cure for cellulite. I think if I do, I could get the Nobel Prize. Well, I still haven't discovered it. But I do want you to know it's not for a lack of trying. Between the lotions and potions, and I was just thinking about this, setting the stage, and the various things I've done and purchased and embraced, starting with, of course, all the lotions and potions, and then endomology, smooth shapes, VelaShape 1, 2, and 3, a little bit of Body by Thermage, then Cellulase, which was laser, focused laser, then Selfina. And if you look at all the technologies I purchased, it's a pretty big capital investment. And we're not even distributing many of those now at this point. So frankly, it's been a failure in my estimation. And we talk about 90% satisfaction rate in aesthetics. We're not even close to 90% with cellulite, perhaps until now. So with us are 4 esteemed experts, plastic surgeons who have a lot of experience in this field, and I'm going to interview them, and you can feel free also if you want to ask them some questions, but I'm not going to introduce you. Everyone knows who you are. Your names are up there. I want to get right into the crux of it. So my first question for you, because a lot of people have asked me this, a lot of the investment community, just how big of a problem? I know that we talk about 90% of women have it and, after puberty and so forth, and we saw the market size by one of the presenters. But in terms of your practice, Holly, and we're going to go right on down, is this a real problem? Is this something that patients talk to you about, or is this something we're just making up?
They typically bring this up when I'm talking about body procedures, and it's always something with the abdomen, and then what can you do about this? And in the past, it's always been, you have fields of cellulite, there's not much we can do. So I have this conversation several times a week.
Okay.
Great. Firstly, thank you so much for having me here. Humbled to be in the same room and now part of the solution with so many aesthetic problems, so thank you. With that said, this is a very common problem. I think for the longest time, it hasn't had, obviously, great solutions. So there's been a lot of lost interest or almost a lost cause where patients just want to move past this issue and be like, what else can we do for my liposuction or other body contouring? Now that the awareness has started to increase, I'm finding that a substantial number of patients, probably over at least 80% in our practice, that are opting for a body contouring procedure are asking about what can be done about their thighs or their butt and are interested in smoothening that appearance. The problem is there's just not still as much awareness on what is actually cellulite versus laxity, but the conversation is happening consistently.
Okay, but Rob's presentation would establish that also. How about you, Laura?
Same thing. I mean, mostly women are just frustrated because all these procedures have come out, like you described, over the last 20 years, and all of them have failed. So they're very skeptical. So they're like, you don't have anything for cellulite, do you? And so now I obviously do. I think the different technologies that I've used in the last 6 years have been very helpful for some dimples, but not even close to what my expectation is a 98% patient satisfaction rate, and it doesn't even come close. But as you mentioned, laxity is huge, so we have to educate as well, so we can take care of the depressions now, I think, pretty successfully. But the issue is, can we take care of the laxity? So I think the complex issue has not been solved, but certain parts of it, I think, now have been solved.
Okay, we'll come back to that. How about you, Jen?
Thank you for having me. I'm
welcome.
an AIS virgin. Super fun to be in a room with intelligent, innovative people. Fun conference, so thank you. Cellulite, kind of the holy grail. I've been in practice for 22 years, and I've always thought, hey, if there's really something for cellulite, this is going to be great. I think no different than hair loss for men, cellulite for women is a really, really big deal. The first chat today, where we talked about the thoughtful Gen Xer and the daring and healthy millennials, you know, there's so many things we have in our practice that really fit certain demographics. This really fits the demographic for all women, you know, and we're seeing women, you know, from 20 to 70 that, you know, this is significant. So, you know, when we say 90% of women out there are bothered by cellulite, 90% of women are bothered by cellulite. And so it's really fun to have things in our toolbox to take care of this problem.
Okay, thank you. Now, before we talk about the technologies, what do you think the price range, the spend range is in your community or nationally that a patient would be willing to spend for a one-time, or we can even include Quo for 3, for resolution to the results you saw here up on stage? What are your patients?
It depends on the degree of their problem.
Okay, fair.
So people who have the fields, they will pay a lot. I mean,
Give me a range and an
I
average,
would
say.
say 8,000. But if you have, say, 5 dots on your buttocks, it goes way down.
Okay,
3.
so the degree of the disease, if you will.
Right.
Okay, how about you?
I think a range of 5 to 10,000 is reasonable to treat this problem in perpetuity.
Okay, Lori?
In my practice, mild, so a few, you know, dimples or a few areas, about 3 to 4,000. Moderate, 5 to 10,000, and severe, they would pay for a car, you know, 40,000, if they could be guaranteed, you know, the result that they're looking for.
Okay, there's no guarantees.
Exactly.
How about you, Jen?
I'm Upper Midwest. I would say ranges 3,500 to 5,500. And in the last 4 weeks, we've done at least 4 to 5 cases at 4,950.
Okay. Well, as long as you're on that, tell us, what are the technologies you're offering today in 2022? Of the 3 we just heard,
Yep.
which of those 3 are you offering today?
Selfina.
Okay.
Oh, shoot. Of those 3. Quo and Avali.
Okay. Let's come right on down that way. Lori, what are you offering today?
Quo, Avali.
Okay.
Same.
Same.
Okay. So no one here has done Rasonics yet. Okay. Fair enough. So, Holly, you offer both of them. We're not here to bash any technology. Tell me what you like most about Quo.
I like that it is a one-time procedure, that you can really ensure that you are treating the septine. You know,
Hold on. We're talking about Quo first.
I'm sorry.
It's all right.
I'm sorry.
That's
I was
right.
talking about Avali.
Yes, we'll go to that, I promise.
I personally don't have experience with Quo. It is offered in our practice. I only have experience with Avali.
Okay. And tell us what you like about Avali.
Avali is very discreet. You have a problem spot, and I can test it and ensure that I am treating their spot, and I know that I fixed it. And so I love the success rate. And I don't think that we used to do Selfina. I don't know that there are lots of technologies out there that are as discreet.
Okay. What do you think?
So we have a pretty substantial experience with Quo, done several treatments, been part of at least, I think, 4 or 5 clinical trials as well at this point, and a large commercial experience. What I like about it is focused, targeted treatment. Patients are already experienced with injectables in the practice, so it's not too difficult to take them from what they're already usually accustomed to, but telling them now we're working on it through the body. Many of these patients have already opted for off-label injectables in these areas to camouflage the problem, whether it's like a hyperdilute CAHA or Sculptra aesthetic or PLA. So I think the ease of use, the setup, the time for the treatment, all of those things have made it a very appealing option with now having treated thousands of dimples over the past couple of years. Those are certainly the pros. And if I was talking about Avali, we recently adopted that into our practice, have done a handful of cases as well, and feel very comfortable with it as a surgeon. Again, ease of use. I would say the ability to focus on a specific dimple, target, and then release it and get the tactile feedback in real time makes it very appealing to actually see the release of the soft tissue, superficial to what you're treating, and to be able to see that tethering is really satisfying. So those would probably be the 2 pros, and that's also, again, a pretty straightforward, easy-to-use treatment performed.
And you've done it one time on each patient, and then the QWO, you did it 2 times or 3 times?
Right. So in commercial use, we've done as few as 1 treatment, but up to 3 as well on patients.
On the QWO?
Correct. Yes, sir.
How are you handling the bruising?
Yeah, this is a pretty, this is an important problem, and it's not just bruising. It certainly can get prolonged hyperpigmentation, could be borderline hemosiderin staining. Mitigation of bruising is an important element for trying to make this a successful, consistently usable product in our practice. Right now, it's really been supportive measures. I mean, and that doesn't get you as far as you'd like to go to. So we're looking at different options, whether we're incorporating now oral tranexamic acid or using other modalities to try to decrease the bruising up front. So looking at various protocols. We're working on some studies for mitigation of bruising that are independent for us, but we really are trying to figure it out because it's a problem. It can be, for sure.
With the patients that you have with hemosiderin staining or long-term discoloration, are you using any lasers or energy-based technologies to mitigate that?
So I haven't yet. I know that I've heard that you could use pico lasers or some other lasers to try to decrease it. I've kind of done more of a wait and watch just to understand that process. Every patient is counseled up front to understand that there is a high likelihood that they're going to have some element of bruising or that they will. Not everyone has that prolonged hemosiderin staining, so I'm still watching. I'd say out of probably anywhere from 50 to 100 patients that we've done outside of any of the studies and following them, there's been a pretty small number, less than 5, that have had beyond 3 months. But we're also icing aggressively, which wasn't part of some of the clinical trial protocols, and some other therapies like compression, which seem to help at least nominally.
Okay. So icing, and you're taking some orals?
Yeah.
And are you adding anything to the actual injections?
I haven't yet added any TXA or anything to injections, only because I just don't know how that's going to help with the dosing and everything. So that's one thing that I have not incorporated yet.
Okay. Thank you.
Yep.
Lori, what's been your experience?
With
Both,
Both.
or either.
So QWO, I adopted it pretty quickly because it was kind of exciting to have something so easily, easy to adopt in patients that are used to injections. And what I found was only the very shallow dimples were treatable with 1 injection. So almost all of my patients had, deeper than very, very shallow. And what I did find was failures in the very deep, deep depressions, like a peak depression, which all my patients had. So I was very frustrated with that inconsistency in treating all of the, targeted dimples with QWO, even with 4 sessions, because I did a 4th on those patients, still could not get them treated. And these are on the buttocks, because when I started using QWO, the thigh protocols weren't really known. Then with Avali, what I've found is that, yes, it's a little bit of a different conversation, because one is in 3 injections, but it does take 4 to 6 months to see the result, because you've got the bruising and a little bit of staining and all that resolves. And I agree with you, most patients resolve the bruising and staining. I do lots of different things for mitigation. But I do have a couple patients that even at 6-8 months still have some staining. And I tried IPL, which did not help at all. It actually inflamed the area like 6-8 weeks after the treatment. Avali's been easier to deal with because the patients are all 100% happy so far. Because there's, at the time you release a dimple, there's 4 to 20 septa that you can identify, then release, and you've released that dimple completely. So everybody's happy so far. But it's early experience, of course. Bruising occurs with Avali too. So working intensely on sort of best practices to how to decrease the bruising so that I don't have to deal with the prolonged staining.
Okay.
I think it's all been said. But
Tell us what you're doing.
I think for me, one of the biggest things is, we've been talking about 90% efficacy, and I think that's so important to remember. And you never want to trade one problem for another. And so, it's easy to take away a dimple, but yet leave hemosiderin staining or a bunch of pockmarks like we used to do with Sulfina. And so, in my experience, I have a lot more experience with Avali than I do with Quo. I will tell you, I echo Lori, I have 100% happy patients with Avali. I've had some hemosiderin staining with Quo. And also just the fact that you can identify subsize and verify. It's kind of a big game changer for us, but I'm a cutter, so kind of makes sense. Again, I think it's just so exciting that we have so many smart minds working on this and that we have many things to use for this. But I'll tell you, in my practice to date, Avali has been a big game changer.
Okay. So all four of you have used Avali, and you subsize, and you verify, and so forth. Have any of you put any filler, fat, Sculptra, anything in the area where you've subsized, where you've released the dimple?
Not as of yet, but I think that's untapped, and I will start doing that in the OR all the time.
We have on our first few cases, 2 of the patients have returned, and we've done some hyperdilute radius so far, and also some Sculptra.
And how do you like it?
I think it's great. I think, especially for the thigh, because the undulations and the pattern that we identify cellulite manifests differently. So the fact that you can just sort of spackle in or smoothen that out has been really nice. I mean, the hyperdilute radius obviously gives you more of an immediate fill. We know that once the water absorbs from the Sculptra, we need the PLA to do what it's going to do to stimulate all the neocollagenesis. But across the board, it's been a really nice just sort of softening and smoothing of the area.
Can you compare and contrast the buttocks with the thigh and how you might approach it differently?
Sure. I mean, I think we do perform buttock augmentation with fat grafting in our practice, and I find that there's a strong possibility that I'm going to use Avali in conjunction with those procedures to release some of the septae, because one of the things that I do find when I do track my long-term patient outcomes is on the patients that do actually have some substantial tethering or dimpling, the fat always seems to just sort of herniate around, and you still have some flattening in the central or inferior mound of the buttocks without any type of release or subcision. So historically, we would do it by trying to separate away with our cannula while we're operating, whereas here, in a matter of just a couple of minutes, I could likely release a few of these septae and then lipofill at that time to sort of stent the tissue open and have a more smooth contour. So I think combination therapy will be really important. You don't have the same benefit for the thigh as much unless you're doing the hip dip or something, because you're not going to treat the posterior thigh with fat, because no one really wants that area to be overly augmented. So that's where I think a neocollagenesis pathway is going to be more important in combination therapy. So if I would contrast them, I'd say that you need a bit more release and separation on the buttocks, and you need to be a little bit more cognizant on the thighs, so you don't either bottom out, release the inferior gluteal fold, or have any of the sort of banana roll that drops in the buttock, loses support. So you have to be a little bit more, I think, careful or cautious with any type of tissue release on the thigh, but you have a little bit more freedom and flexibility on the buttock.
Thank you. Lori?
I addressed laxity of the buttock and thigh a few years back with a hyperdilute calcium hydroxyapatite and L-therapy combination. So now I've got patients that I treated with that for laxity of the outer thigh, buttock area. Now they're coming back for the dimple release, because in my mind, I want to make everything tight, and then I want to release the dimples as opposed to the opposite approach. So it's kind of interesting. But of course, new patients, the question is, how do you stage this? I'm not comfortable doing, the heating up of the septa with all therapy, and then biostimulating, let's say, with some dilute Sculptra or radius, and also doing a release. I'd rather get the skin tight and then release, but that's, just me.
And are you backfilling on your with your experience with Quo or your experience with Avali? Are you putting any fillers in of any type,
No.
autologous or otherwise?
No.
Okay. How about you, Jen?
I have not started combination therapy yet. I think that's the next game, to figure out the recipe, what goes first, what goes second. Because, lower body rejuvenation it's needed, it's hot, everybody wants it. And I think, so we have a lot to figure out with everyone in this room and this panel. what that exactly looks like. But I've thought about fat, I've thought about filler, I've thought about sculpture, I've thought about just so many things. So that's part of the fun.
Do you have any insight into buttocks versus thigh? You said you're primarily doing the ovally.
Yeah.
Any thoughts about buttocks, thigh? Are you treating the thigh? And if so, how is it the same? How is it different?
Yeah, I think of the buttock as like the home run. That's the easy fun part because it's hard to screw that up and make anybody not completely happy with it. I think where you have to be careful with setting expectations with our patients is with the posterior thigh and the lateral thigh. And, I think you just have to be really careful not to over-subsize. And then I think, again, what's going to come into place is, skin tightening and filler and how can we render these ladies with the best result so that they can comfortably wear their Lululemons and wear their shorts and, just be their best selves.
And I don't even think we've addressed the knee area or the medial thigh. So, there's still a lot to learn and understand, because this market is a gazillion-dollar industry.
And like you said earlier, skin laxity is huge, right?
Huge.
We've been talking about dimples, cellulite, but you mentioned earlier skin laxity. And then we could go on about how do you separate laxity versus cellulite? How do you as a clinician actually establish what you're looking at and so forth? However, I'm out of time. We're out of time. And I have to keep myself on time. Or I have to squirt myself with the squirt gun. So thank you very much.